Welcome to Neurologic and Neuromuscular Disorders. We're going to discuss the components. We'll also identify the most common central nervous system. Lastly, we'll describe tests available to quantify respiratory. So let's get into it. Let's talk about neuromuscular control of respiration. So we've learned about neuromuscular control. The main inspiratory muscle is the respiratory muscles. The accessory muscles of respiration include, again, the sternocleidomastoids, the scalenes, the trapezii, the latissimus dorsi, the platysma, and the pectoralis groups. These groups are active predominantly with increased work of breathing, such as exercise or loss of functional residual capacity. This can occur with infection or with neuromuscular weakness. By contributing to ribcage expansion, these muscles support inspiration during active ventilation, although some function also during quiet breathing. The respiratory control system. The respiratory control system is divided into both voluntary and metabolic control systems. Voluntary control regulates ventilation affected by sleep, pain, or anxiety. Metabolic control is mediated by the ventrolateral pathways and incorporates inputs from the central chemoreceptors within the medulla. The peripheral receptors in the carotid and aortic bodies respond to fluctuations in oxygen levels, primarily. Various receptors operate via feedback loops that help to contribute to respiratory drive and regulate ventilatory pattern in most normal physiologic states. In addition to mechanical receptors in the lungs and airways, there are receptors that provide feedback to the respiratory centers and stimulate spinal reflexes that further regulate the breathing pattern. Examples of mechanical receptor control include the Herring-Brewer reflex, which prevents overinflation, coughing, bronchoconstriction, and the recruitment of accessory muscles during respiratory distress. Related mechanical receptors in the upper airway can induce coughing to help protect the airway, glottic closure, vagal stimulation, and the hiccups. The bulbar muscles. The bulbar muscles are not related to ventilation, but are important in protecting the airway and secretion clearance. The bulbar muscles are innervated by the motor neurons. These come from the brainstem. The muscle group controls the epiglottis and other glottic structures like the tongue, the mouth, the larynx, and the throat. Bulbar muscle weakness can impair swallowing, coughing, talking, and other throat and pharyngeal activities. Bulbar muscle weakness can also lead to severe fixed and variable extrathoracic obstruction in the upper airway on forced inspiration and expiratory respiratory effort. Examples of forced respiratory efforts include coughing, sneezing, respiratory distress, and PFT testing. Neuromuscular diseases that affect the respiratory system. Neuromuscular disorder is a broad term that encompasses many diseases that affect muscle function, either directly via muscle pathology or indirectly via nerve pathology. We'll start with the central nervous system. Conditions in the central nervous system that affect respiration include either those that affect the brainstem respiratory centers or the pathways connecting these centers to the motor neurons in the spinal cord. Disorders of the brain. One of the best examples of a central nervous system disorder that affects breathing is congenital central hypoventilation syndrome, or CCHS, also known as Odin's curse. This represents a condition of underventilation associated with sleep. The name refers to the mythical character of Odin, professing his love with every waking breath, and was cursed by a water nymph he betrayed to stop breathing when he fell asleep. Although almost all cases of CCHS, or Odin's curse, are congenital, affecting approximately 1 in 200,000 live births, it can also be acquired through spinal cord or other CNS injury. CCHS is manifested by nocturnal hypoventilation and respiratory arrest and is diagnosed by polysomnogram or sleep study and treated with lifetime nocturnal mechanical ventilation or phrenic nerve pacing. Other cranial conditions affecting respiration in infants and children include congenital disorders like hydrocephalus and anencephaly, water on the brain, and having no or very small amount of brain tissue, along with genetic neurodegenerative disorders like Tay-Sachs disease and Friedreich ataxia. Acquired CNS disorders include cancer, infarction, hemorrhage, and anoxic brain injury. All of these conditions are associated with multiple organ system failure, resulting from diffuse neurologic injury and loss of autonomic control. Respiratory symptoms include changes in respiratory driver pattern, respiratory and upper airway muscle weakness with loss of airway clearance ability, and chronic aspiration. Disorders affecting the spinal cord. We'll start with trauma. Almost 11,000 Americans sustain a spinal cord injury every year, costing about $9.7 billion in healthcare expenditure. The spinal nerve roots that control the diaphragm exist at the spine at the level of the cervical vertebra. Spinal cord injury above the cervical vertebra, number 3, will require tracheostomy and mechanical ventilation or phrenic nerve pacing. Spinal cord injuries between vertebra 3 and 5 will have variable amounts of respiratory impairment, and those below the 5th vertebra almost always allow independent breathing. However, the abdominal and intercostal rib muscles involved in cough function, those are in the lower thoracic spine, and therefore lower spinal injuries may permit spontaneous respirations, but may have a significant impact on airway clearance mechanisms and need your help. Chiari malformations are congenital malformations characterized by a small or misshapen skull, causing the cerebellum to protrude through the bottom of the skull into the spinal canal. Under these circumstances, the brainstem, spinal cord, cranial nerves, and the cerebellum may be stretched or compressed, and the cerebral spinal fluid around the brain and spinal cord may be obstructed, causing hydrocephalus or a cyst to form within the spinal cord, known as spiromelia. Estimates indicate between 0.5% and 1% of live births have Chiari malformations. Symptoms are variable and related to affected areas. Many patients with Chiari malformations report no symptoms, but symptoms include headache, dizziness, vision changes, muscle weakness, or balance problems. Younger children may present with difficulty swallowing, choking, irregular breathing, or apnea. Chiari malformations can be easily diagnosed with MRI imaging and are treated surgically. Other conditions that are less common that cause spinal cord impairment include spinal tumors, infections, and birth injury. Peripheral nervous system disorders. We'll start with disorders of the motor nerves. Acute paralytic poliomyelitis, or polio, was once the most common neuropathy in the United States. However, immunizations have effectively wiped out polio in the United States. As a result, the spinal muscular atrophies are now the most common cause of degenerative nerve cell disease in children. Spinal muscle atrophy, or SMAs, include a number of different disorders that clinically manifest as muscle weakness and as a result of progressive destruction of the motor neurons of the spinal cord and the brainstem. SMAs are hereditary and are transmitted by autosomal recessive inheritance. All types are caused by defects at the same site on chromosome 5, and they overlap in clinical features. SMA type 1, also known as Wernicke-Hoffmann disease, is a acute infantile form which usually presents within the first 6 months of life. Children often develop limb weakness rapidly, and the facial muscles are slower to start to fail. Extraocular muscles are essentially spared. The result is a child who appears alert and responsive, but can't move. Respiratory efforts in SMA type 1 include weakness of the bulbar muscles, abdominal muscles, and intercostal muscles, making feeding and coughing difficult, and aspiration a complication. SMA type 2, is a chronic childhood form and has a later onset and is often more insidious. Some affected children may be able to sit unsupported, but usually have proximal muscle weakness that prevents them from standing or walking. This can lead to scoliosis, and eventually these children may become wheelchair-bound. The course of SMA type 2 is unpredictable, with long intervals without progression of the weakness, and survival into adulthood is very common in SMA type 2. SMA type 3, Kugelberg-Wieslander disease, is the mildest form of SMA. It affects patients. Affected patients are able to stand and walk independently and have a much slower progression of muscle weakness compared to the type 1 and type 2. Polymyelitis. Polymyelitis is an infection, or polio. It is caused by the polio virus and was one of the most dreaded childhood diseases of the 20th century in the United States. Most infected individuals are asymptomatic or experience only mild nonspecific symptoms, but a small portion of patients, the virus enters the central nervous system where it infects and destroys motor neurons in the spinal cord, leading to muscle wasting and weakness. Most commonly, this causes a self-limiting case of non-paralytic viral meningitis, but in a small amount of patients, the infection causes permanent wasting and paralysis. Depending on the site, Polio is classified as spinal, affecting the nerves of the trunk and extremities. Bulbar, affecting the nerves that control breathing and speaking and swallowing. Or bulbar spinal, affecting both. Destruction of these nerves makes independent respiration, swallowing, and coughing impossible, and requires lifelong ventilatory support and airway clearance. Guillain-Barré syndrome, or GBS. This is an acute inflammatory demyelinating polyneuropathy. It is an acute autoimmune process that affects the peripheral nervous system, stripping them. It is not hereditary. There is a lot of research going on, and we still don't know why it happens. So we do know that it happens usually post-viral or bacterial infection. The incidence ranges from 1 to 3 per 100,000 of population, and although the cause is not completely understood, they do think it's triggered by an acute infectious process, leading to destruction of the myelin sheaths that coat the peripheral nerves. It presents as ground to brain, ascending muscle weakness and paralysis that starts in the legs and spreads to the upper limbs and the face and the diaphragm. Most of the time, respiratory paralysis occurs in about 14 to 18% of children with GBS and about 20% of all patients with GBS. They will need to be in the intensive care unit during the acute phase of the disease. Treatment is mostly supportive, although corticosteroids, plasmapheresis, and IV immunoglobulin have all been used with varying rates of success. Plasmapheresis is considered the treatment of choice in adults, and certain technical factors may limit its usefulness in small children. Careful monitoring of patients' respiratory status, accompanied by intubation and mechanical ventilation when the diaphragm is involved, is the mainstay of supportive care. Disorders of the neuromuscular junction. Disorders of the neuromuscular junction include infantile botulism, myasthenia gravis, and a few others. We're going to start with infantile botulism. Infantile botulism is human botulism that results from eating food contaminated with Clostridium botulinum, the toxin it produces. The clinical spectrum of infantile botulism ranges from those that have no symptoms and are just a carrier to severe with progressive life-threatening paralysis or even sudden death. Most infants experience symptoms of constipation and poor feeding, followed by progressive bulbar and skeletal muscle weakness and the loss of tendon reflexes. On examination, typical features include diffuse hypertonia, ptosis, dysphagia, and a weak cry. There can be also respiratory insufficiency and apnea. Diagnosis is confirmed by isolating C. botulinum organisms in the baby's stool. In general, botulism is self-limiting. It lasts 2 to 6 weeks, and even with the use of immunoglobulin therapy, an infant requires supportive respiratory care and, in severe cases, intubation and ventilation. Myasthenia gravis. Myasthenia gravis is an autoimmune disorder characterized by fluctuating muscle weakness and getting tired easily. The pathophysiology of the disorder occurs at the neuromuscular junction where circulating antibodies block synaptic receptors, acetylcholine, inhibiting the effect of those neurotransmitting chemicals. This prevents muscle contraction. The current prevalence of myasthenia gravis in the United States is estimated to be about 20 per 100,000 people, although frequent misdiagnosis means it may be higher. Juvenile myasthenia gravis describes the immune-mediated form of myasthenia gravis that occurs in late infancy all the way through adult life. There are two forms, ocular and generalized. The initial features of both ocular and generalized forms are usually ptosis, diplopia, or both. Prepubescent onset is associated with a slight male bias and ocular symptoms only, where post-puberty onset is associated with strong female bias and generalized myasthenia gravis. Patients with myasthenia gravis often have little chronic respiratory compromise and are symptomatic only during periods of myasthenic crisis, where symptoms, particularly the ability to swallow, suddenly escalate. During a crisis, patients may have sudden paralysis of the respiratory muscles, temporarily requiring intubation and ventilation. Treatment includes cholinesterase inhibitors to help the transmission of acetylcholine and immune suppressants such as corticosteroids and cyclosporin. Exchange transfusions and IV immunoglobulin therapy rapidly restore function but are temporary fixes. Other conditions affecting the neuromuscular junction include incomplete or failed transmission at the neuromuscular junction relating to drug exposure, medications including antibiotics, corticosteroids, antirheumatics, lidocaine, lithium, and anesthetic agents can also interfere with incomplete or failed transmission at the neuromuscular junction. Let's talk about myopathies. Myopathies are diseases of the skeletal musculature causing muscle weakness and degeneration. Myopathies are caused by inherited genetic defects and also by inflammatory, endocrine, and metabolic disorders. We'll start with Duchenne and Becker muscular dystrophy. The muscular dystrophies are a group of genetic disorders with multi-system symptoms, including cardiac, respiratory, gut, endocrine, and nervous system. Although there are more than 100 diseases that have similarities to muscular dystrophy, the two most common muscular dystrophies in childhood are Duchenne and Becker muscular dystrophy. Duchenne muscular dystrophy, or DMD, is the most common childhood form of muscular dystrophy, occurring in roughly 1 in 3,500 live male births. The male predominance is related to its inheritance pattern. DMD is on the X-linked genetic disorder, resulting in female carriers and affected males. DMD presents early in childhood with proximal muscle weakness, which manifests as difficulty in running, climbing stairs, and standing. By adolescence, almost all DMD or Duchenne's muscular dystrophy patients are wheelchair-bound and require assistance with ventilation. Becker muscular dystrophy is also X-linked inherited muscular dystrophy. It has muscle wasting and weakness similar to Duchenne's. However, Becker muscular dystrophy typically has a milder course, with symptom onset in the second decade or later. There is no cure for either of these muscular dystrophies, and current therapy is supported. Treatment goals are to maintain functions of daily living, prevent contractures, and provide psychological support for the child and family. 90% of patients with Duchenne muscular dystrophy die of respiratory failure before reaching 20 years of age. Myotonic dystrophies. Myotonic dystrophy is highly variable inherited disease characterized by chronic, slowly progressive muscle wasting, weakness, contractures, heart conduction defects, and endocrine disorders. The muscles commonly affected are the voluntary muscles in the face, neck, lower arms, and legs, and in more severe cases, the intercostal muscles and diaphragm. Myotonic dystrophy commonly presents in adolescence or adulthood, but a severe congenital form exists and is associated with mental retardation, orthopedic problems, and other developmental delays. Affected infants are extremely hypotonic and may have difficulty feeding and often require ventilatory support. The overwhelming majority of affected children die in infancy with congenital myotonic dystrophy. However, supportive ventilation, corrective surgery, and tube feeding have extended the lifespan of patients and dramatically improved the quality of life for these children and their families. Glycogen storage diseases. The glycogen storage diseases are a family of 12 inherited errors of metabolism that result in enzyme defects in the glycogen synthesis or breakdown. In general, clinical classifications can be made on the basis of whether the affected organs include the liver only, or additionally the muscles, blood cells, connective tissue, heart, brain, and kidneys. In terms of respiratory involvement, glycogen storage disease type 2, also called Pompe disease or acid maltase deficiency, I've always heard it called Pompe disease, has the most severe symptoms. Pompe disease is a rare autosomal recessive disorder occurring only in 1 in every 40,000 to 100,000 live births. It's caused by a deficiency in the enzyme alpha-1 4-glycidase, which causes glycogen accumulation in the cellular lysosomes and leads to progressive weakness in all of the muscles. The severity of symptoms of Pompe disease are related to age at onset. Infantile onset is the most severe and is characterized by development of marked hypotonia, hepatomegaly, and severe cardiomegaly within several months of birth. Mental development is usually normal, although most children die of respiratory or cardiac complications before 2 years of age. Electrolyte abnormalities. Less common causes of muscle weakness in the outpatient setting include electrolyte abnormalities, most commonly caused by insufficient dietary intake. Potassium is essential for many bodily functions, including muscle and nerve activity. Maintenance of electrochemical gradient of potassium between intracellular and extracellular space is essential for normal nerve function. Mild potassium deficiency is often asymptomatic. However, moderate potassium deficiency may cause diffuse muscular weakness, myalgias, and even arrhythmias. This is particularly important when attempting to liberate a patient from mechanical ventilation, because the respiratory muscles could be in a weakened state, atrophy versus fatigue, and electrolyte abnormalities will only add to the impairment. Severe potassium deficiency has been associated with respiratory depression from severe impairment of the skeletal muscles. Similarly, not enough magnesium or hypomagnesium can cause weakness and muscle cramps that contribute to impairments in respiratory muscle function. So, how can we evaluate children with neuromuscular disease? One of our main ways is with pulmonary function testing. Neuromuscular weakness affecting the respiratory system can develop as impaired cough and airway clearance with gradual progression to nighttime and eventually daytime hypoventilation. Monitoring the respiratory status of a patient with neuromuscular weakness depends on the underlying disease, its rate of progression, and the extent of involvement. Because most conditions involve weakness of both the inspiratory and expiratory muscles, PFT testing includes muscle strength testing as well as polysomnography and non-invasive measures of hypoventilation as the disease progresses. The use of PFT in diagnosing and monitoring the progression of neuromuscular disease is well established in adults, but in pediatric testing, it can remain a challenge. Although newer techniques in respiratory muscle strength testing are being introduced, most school-age children and adolescents are best monitored by standard spirometry with maximal inspiratory and expiratory pressure monitoring. Additional testing includes assessment of cough because it is the main determinant of respiratory compromise. However, because peak cough flows have been well correlated with forced vital capacity, an FVC may be used, and forced expiratory volume in 1 second can also be used. These tests are the mainstay of pulmonary function testing in this population. Most school-aged children and adolescents can be monitored in this way. Arterial blood gases should also be considered, and non-invasive monitoring using capnography as well should be also considered as well. Daytime monitoring should be performed every 3 months or more frequently with diminished mucus mobilization or decline in lung function or reduced peak cough flows. Further progression of carbon dioxide retention and muscle weakness and advancing concerns regarding nighttime hypoventilation, home overnight oximetry, and polysomnography may be useful in determining how much support they need. Do they need a trach? Do they need a ventilator at night? Let's talk about sleep studies in children with neuromuscular disease. Polysomnography must be performed and sleep disordered breathing monitored in all patients with neuromuscular weakness. Nighttime sleep disordered breathing often precedes daytime muscle impairment. Polysomnography is the most complete diagnostic test available to assess the nature and severity of sleep disturbances. Sleep assessment allows for evaluation and more timely recognition and management of assisted ventilation at night. A full polysomnograph should include sleep stage recording, arousal documentation, monitoring of oxygen saturation, hypoventilation, and hypocapnia. Together, all of this testing allows for monitoring of sleep complaints and treatable conditions in otherwise progressive disease process. Some general considerations for respiratory care of children with neuromuscular disease. The treatment will depend on the underlying disease. Onset of pulmonary symptoms in children with neuromuscular disease mostly depends on this. For example, a boy with Becker muscular dystrophy is likely to have few respiratory symptoms until late adolescence or even adulthood, whereas an infant with SMA type 1 will almost certainly develop symptoms in the first few months of life. In either case, a predictable sequence of events will occur. Respiratory insufficiency, and eventually respiratory failure will happen. Respiratory muscle weakness will manifest first as a weak cough and impaired airway clearance, and that leads to recurrent atelectasis and chest infections. As the diseases progress, respiratory muscle weakness progresses, and patients experience nocturnal hypoventilation and symptoms related to hypercapnia. These include nightmares, frequent wakening, morning headaches, and daytime sleepiness. At some point, most patients maintain relatively normal daytime respirations, but have these terrible nighttime symptoms. Many interventions are used to support airway clearance and ventilation in adults, and can also be used to assist children. However, there are some limitations due to size and the inability of young children to follow directions or comprehend what is going on. Although respiratory insufficiency and some form of cardiopulmonary disease is the most common cause of death among children with neuromuscular disorders, pediatric ventilatory assistance have improved and extended the survival and improved quality of life for most children affected with neuromuscular disease. It may be difficult to find the appropriate sized equipment and implement it, but it does exist. The industry of pediatric assisted ventilation and airway clearance is growing year by year. Some airway clearance mechanisms. Airway clearance is achieved by a healthy individual via two ways: mucociliary transport and cough. The mucociliary escalator lines the tracheobronchial tree, and then the cough expels the mucus. Normal coughing is a highly controlled reflex with several defined phases. The initial phase is inspiration, when a maximal inspiration is performed to get air behind the mucus or debris that needs to be cleared. The next phase is the compressive phase, during which the glottis is closed and the abdominal muscles contract. This allows interthoracic pressure to rise and narrows the central airways, making velocity of the airflow higher. Lastly, the last phase of coughing is expulsion, during which the glottis is opened and the air is released at a high rate or high speed, carrying the collected mucus and debris away. Children with neuromuscular weakness can have trouble with any of these phases. They have a reduced vital capacity and a reduced maximum inhaled volume. Bulbar weakness can lead to impaired glottic closure, and expiratory muscle weakness reduces maximal interthoracic and expulsive force. The significance cannot be overstated. In patients with neuromuscular disease, most episodes of acute respiratory failure result from the inability to eliminate airway secretions and mucus during otherwise benign chest infections. A peak cough flow of less than 160 liters a minute in adults is associated with impaired secretion clearance, but early intervention at 250 to 270 liters per minute is recommended for beginning cough assistance. Frog breathing. For effective coughing, sufficient strength is needed. Glossopharyngeal breathing, or frog breathing, can be used to provide brief periods of normal alveolar ventilation for a patient with neuromuscular weakness who spends long periods on a ventilator and short periods off a ventilator during times of unexpected ventilatory failure. The technique of frog breathing is to augment insufflation by gulping air in a series of breaths, closing the glottis between gulps to entrap it in the lungs. Using this method, one glossopharyngeal breath often consists of 6 to 9 gulps of air. During severe bulbar muscle weakness, this can limit the effectiveness of glossopharyngeal breathing, preventing its use in patients that have no independent breathing or vital capacity. This technique has been used to facilitate independent breathing for periods ranging from minutes to all day long. Respiratory care of children with neuromuscular disease. Let's talk about the goals of assisted ventilation. The goals of assisted ventilation are to maintain pulmonary compliance and normal lung and thoracic growth, and to maintain normal alveolar ventilation. Mechanical ventilatory support may be needed for children with neuromuscular disorders. These can range from non-invasive ventilation, ventilation only at night, ventilation at night and during the day with a sip-puff system, as well as supplemental oxygen or even tracheostomy. Generally accepted indications for initiating nocturnal ventilation include rapid progression of weakness, hypercapnia, and increased CO2 and decreased oxygen saturations during sleep, and symptoms of respiratory distress. The level of nocturnal support is adjusted until there is resolution of symptoms and saturations remain greater than 95. Dineural ventilation. Daytime use of ventilatory assistance becomes necessary when patients develop end dineural hypoventilation. Again, the goal of ventilatory assistance is normalization of blood gases and elimination of respiratory symptoms. Ample evidence exists that children, adolescents, and adults who are able to cooperate overwhelmingly prefer non-invasive ventilation. Mouthpiece positive pressure ventilation has now been studied, or a sip-puff program has been studied in several large cohorts of end-stage patients and has been demonstrated to be safe and effective means of chronic ventilation even in patients with respiratory failure and no reserve. It's extremely well tolerated by patients even in sleep, is user-friendly during eating and social activities, and is relatively inexpensive. Supplemental oxygen is often used with caution during acute illness such as pneumonia. During these acute phases of illness, it's appropriate to balance lung protective ventilation with oxygen levels. However, supplemental oxygen can also disguise hypoventilation and atelectasis. The goal during chronic mechanical ventilation titration is to wean the fraction of inspired oxygen to room air. By leveraging normal oxygen levels on room air, you can more appropriately titrate mechanical ventilation settings to minimize atelectasis and provide normal ventilation. Normal ventilation using room air will help prevent complications associated with chronic hypoventilation and hypoxemia. Tracheostomy has long been a part of traditional management for patients with progressive neuromuscular weakness. Although more and more centers are developing expertise with chronic non-invasive ventilation, it's estimated that a minority use mouthpiece positive pressure ventilation. The reasons for this are explained by a combination of family and practitioner unfamiliarity with non-invasive methods and poor availability in some areas, or uncertainty about how to use home cough assist devices. This underscores the importance of connecting patients and families early in their course to avoid tracheostomy if possible. It is important to remember that tracheostomy has been favorably viewed by many patients and parents. In general, it's recommended that patients demonstrate a need for ventilatory assistance, and non-invasive methods have been tried and failed before tracheostomy is established. General medical concerns about non-respiratory considerations. General medical concerns will cross all stages of growth and development for children with neuromuscular weakness, and attention has to be paid to nutritional and cardiac status, the extent of scoliosis and restrictive respiratory disease, as well as the contribution of weakness to other organ systems functioning. You need to also look at the need for communication assistance and mental health care. Some of these concerns, such as cardiomyopathy and dysrhythmias, relate to multi-system failure and the effects of neuromuscular conditions. Others, such as surgical correction for contractures and scoliosis, can be important in maintaining mobility and preserving lung function. End-of-life care issues are also inevitable in the course of progressive neuromuscular disease. In the discussion of these events, it is important to provide facts and answer every question fully for parents and children. The patients can then make an informed decision, and the parents together. We should not use frightening technical language, but use simple terms that can be understood by both parents and children. This is one of the most difficult tasks in providing care to neuromuscular patients. It requires tact, good communication skills, empathy, and complete support of any decisions made by the parents or the patient. The three primary goals should include deciding on an end-stage pain and dyspnea control, providing spiritual and psychiatric support, and respecting the choices of the family concerning tests and treatments. Life expectancy. Improved technology and advances in respiratory care have significantly increased the life expectancy of children with neuromuscular weakness. Many of them survive into adulthood, and the transition to adulthood requires increasing reliance on ventilator assistance, nursing support, and assistive technology to help achieve independent living. Other issues that persist across all childhood chronic illness is the need for age-appropriate caregivers so that older adolescents and adults can begin to receive care in an adult healthcare environment. Children with neuromuscular weakness require more life-sustaining equipment and assistance in achieving independence. Assistance can include personal assistance, either from family or skilled nursing, and basic care needs. Increased support has been associated with not only extended life expectancy, but improved quality of daily life. Unfortunately, the timing of institutionalizing and assistive technology and skilled nursing remains dependent on the individual patient and what is going on. Successful transition requires attention to challenges associated with providing ventilatory assistance to young adults with neuromuscular weakness. Additional issues during the transition process include facilitating coordination of care among multiple subspecialists, establishing a cadre of skilled caregivers, and arranging support for maintaining activities of daily living. If successful, the transition is likely to result in continued maintenance of a high quality of life despite physical limitations associated with neuromuscular disease. Thank you for your time and attention today. If you have any questions, please direct them to me via email.